Then next I would like to invite Dr. MARIAN PAULY Madam. She doesn't need any introduction. Currently she is working as a consultant oculoplastic surgeon at Giridhar Eye Hospital. She'll be covering two topics. One is a logical approach to vascular lesions of the orbit and an overview of orbital tumors. Actually, the last topic was supposed to be taken by Dr. Maneksha sir. Unfortunately, he couldn't join with us due to some health issues. So, Marian Madam will be covering that topic also.
Yeah, good morning. Thank you, Dr. Aparna, for putting up this IC. So vascular lesions of the orbit, I just see practical approach. There are two broad categories. One is tumor, where you get a proliferative endothelium. Second is malformations. So malformations, it's a localized defect in the vascular morphogenesis that can be either in the artery, vein, capillary, lymphatics. Here there is no cellular turnover. So that's the difference between a tumor and a malformation. Now lots of research is going on in this area. That's why I just put across the slide. So malformation, again, as I have already told, venous can be varices, cavernous venous malformation, intraosseous venous malformation, capillary Pottwine stain salmon patch, then AV malformation and AV fistula. Even though it present to us, we need help from interventional radiologists to treat these two. So vascular tumors, the most common which we come across is infantile hemangioma. It is called capillary hemangioma of infancy. Here we have to it's always a clinical diagnosis and we have to understand the natural cause. So usually the child will present around 3 weeks to the small reddish lesion. Sometimes it can present early also and it will start gradually growing. So most of the time when the parents present to us around 2 months or 3 months, and you can get the old photographs and see the natural cause. So then what are the indications for treatment? All the lymphangiomas does not require any treatment. So you have to do refract all these babies. Anisometropia, then any ptosis causing obscuring the visual axis, rapidly progressing hemangioma. So from the old photographs, you know whether it is rapidly progressing or not. If the growth pattern in the last 2 weeks, then you can predict what's going to be the growth pattern in the next 2 weeks. And any surface ulceration, exposure keratopathy and optic neuropathy. So treatment is by oral propranolol. So in my practice, I never start by myself. I always get an opinion from the neonatologist. Starting with the low dose and increasing depending on the response. For me, everything is done by the neonatologist. I just follow up the baby every month till it start regressing. So if it is responding, it will show the first sign of regression after 3 days. I usually combine with topical beta blocker also. So this Timolol-Toddy, I don't have any financial interest. So Timolol-Toddy drops is freely available. What I do is ask the mother to mix with some gel, lubricant gel, and apply over the skin at least twice daily. It also adds to the result. Then systemic and intralesional steroids are described and surgery is also described, again when it is not responding to the propranolol. So this baby was started on propranolol initially, but it was regressing, but still it was causing -4 cylinder. So I went ahead and operated to prevent amblyopia. This is a very ulcerative large hemangioma. So we were also actually wondering what can be done. So we treated with antibiotics, steroids, propranolol. I was planning for debulking, but during the meantime it ulcerated by itself and then healed. And baby is having a mild ectropy on now. Coming to the malformations, so vascular malformations, the most common malformation which we come across is cavernous venous malformation. So we always call it as cavernous hemangioma, but the new terminology is orbital cavernous venous malformation. So simple venous malformation seen in middle-aged, like 30 to 50 years. Here also clinical course can be asymptomatic. So most of the time they don't come with I have got hemangioma. They always come for mild protrusion or sometimes some blurring of vision, or the refraction is getting with frequent change in the refraction because of the hypermetropia. So clinical course can be asymptomatic or symptomatic. And the treatment is there are some indications for treatment, like especially it is affecting the vision or visual fields or optic nerve is compromised. we had to, excision biopsy is the treatment. So actually in this, she is a 44-year-old female, presented to OPD for a glass prescription. So she noticed this protrusion, and she was already undergone thyroid function test. Thyroid was normal. Then, so she was just sitting like that, but I couldn't put her refraction. She had +1 hypermetropia for the distance in the left eye, and the disc also showed a minimal disc edema. So did an imaging and diagnosed as cavernous hemangioma, and then we removed it later. So this is, I'm just showing basically all cavernous hemangiomas, we always cryo-assisted extraction after doing the lateral orbitotomy. The main thing is, like, if it is an accessible quadrant, it is very easy. Otherwise, you have to do combine two approaches, lateral orbit and lid split. So she is doing well at 3 months. So coming to the next most common one, that is lymphangioma. Lymphangioma is called veno-lymphatic malformation. Again, microcystic, macrocystic. So it's seen in younger age group. So treatment is again same as like it is affecting the vision, sudden onset proptosis. So most of the time, the thing is, they will say it is increasing with respiratory infection. So that gives a clue to the lymphangioma. If it is a chocolate cyst, then you can excise. So similarly, he actually presented to us acute onset proptosis, had compression, minimal compression with relative afferent pupillary defect, but vision was holding. His IOP was also high, so I started on oral steroids. And after 3 weeks, it has localized, and then we injected bleomycin, excision and bleomycin injection was done, and he did well. Coming to varices presents with intermittent proptosis. Visible, someday you can see visible lesions. The complications here you can expect is either you can go for a bleed or you can thrombose. Thrombus is good, bleed might not be. So treatment is surgical excision assisted with the glue or endovascular embolization. Usually we do when there is a recurrent thrombosis, pain, severe proptosis, and optic nerve compression. So this is one localized varix mainly involving the anterior orbit from the scans and the conjunctiva. We excised it, and it will bleed, but it is usually venous, so it's easy to control it. Similarly, you can see the phlebolith. This is a thrombosed varix. Her main problem was whenever she stoops down, it will come off and was creating lots of trouble. So again, we did a surgery to a transconjunctival approach, and she did well. Coming to the intraosseous malformation, this is a little tricky. So this is a young patient presented with acute onset bleed, acute onset proptosis. So scan, you can see there is a well-defined lesion in superior orbit. At the same time, you can see a small defect in the bone with the lesions in the frontal bone also. We actually thought of, when we saw this defect, we thought of something inflammatory, but we intraoperated, it was bled, and then removed the bled and cauterized the lesion. But he had a recurrence recently. I'll just share one case. Like, vascular tumors are always very tricky, even though this is one patient, 28-year-old, left eye proptosis 5 years, treated as lymphangioma with the sclerotherapy, with the bleomycin, cyst aspiration, etc. 10 times. So this was a CT scan. So you can see some cyst, and there is a solid component also. So initially we also thought it as probably we will go ahead once again. And she was doing Ayurveda also in between. So during the, we posted for her debulking cyst aspiration, we did a biopsy, but initial result was hemangioma. So again, we were also confused, is this hemangioma? So then we looked into her old MRI, so this was her initial lesion. So this was not characteristic of lymphangioma. Then we did a repeat biopsy and did immunohistochemistry. It turned out to be solitary fibrous tumor. So further she underwent DSA, interventional radiology, tumor embolization, followed by surgery. So vascular tumors is very, very challenging sometimes, and the clinical presentation is also variable, acute onset proptosis, sudden loss of vision, etc. Diagnosis itself is challenging, so as the treatment, and needs logical approach in almost all the cases, other than probably capillary hemangioma of infancy. Thank you. Any doubts regarding vascular?